Morning, Maya.
Good morning, Glenn.
Oh, did you pull up the agenda?
I did. I just pulled up the package and I'm happy to keep
Oh,
sharing or if you want to take
no,
over
no,
the screen.
since you're going to do the presentations, if you want to just, God, you're making me look bad. I was supposed to facilitate. Yeah, just teasing.
Oh, I'm
No,
hard
thank you.
hard at
Thank
work
you.
sharing. You bet. Thanks, Glenn.
Oh, how are things in Tucson there?
Tucson is bustling with a gem show.
Oh,
So, kids are back in school. Snowbirders are here. And there are a ton of people for gem show. So it is very busy.
Who was supposed to bring the coffee? Rose is not with us all day today. Is that correct?
That's right.
All right.
That's right. So good morning, everyone. We've got about one more minute and we'll get started.
Kimberly, was it near your turn to bring the coffee?
Yeah, right. I've already had two. So if I start buzzing around here like a little buzz, and no breakfast yet, vitamins and coffee. That's my morning. A noon, I'll get something in my belly. But
That
it's
is the
9 o'clock. It's not a good, and it's not a good habit to be in. So everybody, I want to welcome you to the OEB and PEB Strategies and Evidence and Outcomes Workgroup, SEOW. Today is Tuesday, February 3rd, and we are going to call this meeting to order. And first, I'm going to see if I have my committee members present. I'm Kimberly Hendricks, and we've got Bill.
Sure.
Okay,
Here.
and then Dr. Laura.
Here.
Good morning. Greg Klauser. Robert.
Don't see him.
Good morning, Robert. All right. Well,
And-
he might
and-
join us later. I don't know what kind of assignment he has.
Is Andrea here?
Yes. Oh, Andrea, sorry. Nope. Maybe she'll join too. Maybe I'm a little too Johnny on the spot here this morning. So we'll watch to see if they join us. Need to move everybody to the top of my screen instead of the side. So technically, do I have enough for us to go on to our next agenda item, the meeting synopsis?
We have 4 out of 6.
So we should be good. All right. Does anyone want to make a motion about the meetings?
I'll move to approve the synopsis, but I have a comment about it or a question.
Okay. So Bill makes a motion to approve with a question.
Maya, could you forward to the synopsis?
And we'll do the second and then we'll go to the question.
Correct.
I wasn't here December, but I don't mind seconding the motion.
Okay, thank you. All right. What page is your question on, Bill?
On page 4 of 7 in the meeting synopsis, towards the bottom, it says clarification and closing. In the first bullet, I kind of got lost in the acronyms. I'm not sure what the first bullet means.
Oh, well, OEM is the Office of Emergency Management, and oh wow, that's a typo. Just PEB members for PEB.
So it's supposed to be OEB
and what
PEB.
is OA members?
No.
Maybe OWeb Active? I don't know.
Yeah, let
that's-
me double check with Rebecca on that, but
I mean, I just think if we approve this, just clarifying that one sentence or that comment, I'm
Yeah.
not quite sure. I'm sure it has
I'll
meaning,
get
but
that.
I don't know what it means.
I'll get that clarified from Rebecca.
Otherwise, we're good, in my opinion. Right.
Boy, I'm trying to think back of what we were talking about, Bill. Do you remember
I
what we
don't.
were?
That's my problem. Is it not triggering? It's
Okay.
so
Oh, it's the
it's-
performance guarantee.
OA is well, that's the topic, at hand, right? But anyhow, if we can just make that sentence a little clearer,
Okay.
what was happening there. Right.
Sorry about that.
No worries.
Okay. Any other questions or comments? Sorry, I don't know how. Let me turn this thing off. Okay, and then so do we have a vote on accepting the minutes as amended? So I've got Dr. Lara,
Yes.
and then Robert was the second, and then Bill was the first,
Yes,
and then did Greg Clauser join us yet? Or Andrea? Okay, so then I vote yes also, right? So that gives us 4 of us.
Yep.
Perfect. All right, so we are going on to our first up is our vendor partner performance review. And this, I'm sorry, it's Mercer. I don't have a name of who is going to be, and I apologize for not remembering who will be doing this part of the presentation. Good morning.
Good morning, then that's totally fine. This is Rob Foy. I will kick us off, but really the whole well-being team with Katie and Kalia will also be contributing to this section because we have quite a lot to get through here. So I will kick this section off, however. Nice to see you all. All right, I think we can move forward. Okay, as I alluded to already, this section has a lot of content in it, and so we will get through it all in the next couple of hours. We'll provide a brief introduction as to really setting the stage for what we covered here just shortly. But then we really want to get into the meat of the overall evaluation and looking at these partners and their performance. We will break down the assessments that we gathered by category. So we will start with those vendors that touch diabetes prevention, then those that discuss weight management, those that discuss diabetes management, so managing the condition when somebody has it, and then general lifestyle coaching. And then after that, we will present some recommended action steps based on the findings. Okay, we can move forward. All right. Okay, so the sort of looking back and how we've gotten here, it's been a lot of accomplishments, looking into this work, and really we've gotten to the end of the project itself. So, what we really aligned on a holistic multi-year approach in April 2023 to include vendors including Virta, Omada, Weight Watchers, Weight Management, and Mighty Health. Then in April, a year later, this group took a review of Virta, Livongo, Omada, Weight Watchers, and Predi, and then recommended renewing for another year in 2025. And then late 2024 to early 2025, PEB staff and Mercer did a deep dive into the Omada Diabetes Prevention Program. And that deep dive did result in some observations that did suggest some room for improvement. And we'll get to a little bit more on that as we dive into the specific vendor results. We also, you'll remember, I think earlier in 2025, this group also did a vendor performance management report on the behavioral health topic. And so this is a similar review, but looking closely to those vendors that touch diabetes and associated comorbidities. So here we are. Since April, we have sent out data requests to vendors, all of them that touch these specific focus areas, and then are now presenting the findings of the metrics that we asked for in that reporting. Okay, we can move forward. So the goal of this exercise is really to evaluate the vendors that touch OWEB and PEB members with the goal of improving outcomes, value, and efficiency. One outcome that we do want to get to as part of this exercise is to implement standardized reporting criteria across the carriers and third-party contractors. We'll get into some detail on that and where there's room for improvement on that as we go through the results. And then just to reiterate, this current review is focused on members who have type 2 diabetes and associated comorbidities, which include pre-diabetes and weight management support. The objectives of this exercise are to review those evaluation results. We'll identify some key themes and insights and then talk about recommended action steps from there, noting that there are actually different action steps for OWEB and PEB just due to the different mix of vendors for each unit. Move forward. And this is probably a fairly familiar slide to most of you, so I won't spend that much time on it, but this is really just to speak to the aligned core values for both OWEB and PEB, and then how that translates into the vendor partner programs. And really aligning us to the fact that we want vendor partners to help close gaps in care, provide specialty care to really improve equitable access, quality, and equity across the populations. Also, the goal is for the vendor partners to help reduce member out-of-pocket costs by providing access to care and services at low or no cost. So really reducing out-of-pocket and affordability and tying to the goals there. And then also for them to support member education and member experience. So, helping individuals via the services, content, and coaching that they provide to help members better manage their condition. On. Just some really quick demographic slides and the population that was evaluated. This is as of mid-2025. So the data we're looking at is 2025 data. So this really sets the stage for the vendors. We're looking at the population that we're talking about and how they are spread across various medical plans. What the specific demographics are. So just a repeat of what is actually covered in this analysis. Move forward. And then another snapshot is to look at just the cost of the associated conditions that are associated with type 2 diabetes and the impact that this actually has. And the total spend as of April 2025 was $67 million, just over $67 million. And you see all of the various comorbid conditions that all relate in some way to diabetes and this set of conditions that we call cardiovascular, cardiometabolic, and related, and the impact that it has on the PEB and OWEB populations. And the reason why we're looking closely at it and aligning with those outcomes. Okay, we can move to the next slide. So, and to speak specifically about health equity and the need aside just for cost of these conditions, and this is really the goal to reach more OWEB and PEB members. 9% of adults in Oregon have diabetes, across the US, it's around 75% of adults either are overweight or have obesity. And then hypertension is another comorbidity with these conditions, and 34%, a third or so of those adults in Oregon have been diagnosed with hypertension. It's also quite prevalent in specific populations. American Indian, Alaska Native, non-Hispanic, Hispanic, and Asian populations have higher diabetes prevalence than the white population. Also, socioeconomic status has an effect, as does the neighborhood, walkability, and additional social factors that all impact this slate of conditions. So we did ask quite a lot about health equity in this review and continue to keep that a focus of the analysis. For the next slide. Right, so let's get to the fun stuff, the evaluation piece. All right, I'll do some more stage setting here because this is a really complicated list of vendors, and really want to orient you to what we looked at overall. You'll see of the three health plans that serve OWEB and PEB, there are different solutions that address the various conditions. So for Kaiser, that serves both OWEB and PEB, OMADA provides support for preventing individuals with diabetes. And it's important, I think, we can also talk about the fact that the diabetes prevention and weight management are different. Diabetes prevention are for individuals that have a diagnosis of pre-diabetes. And that's different from somebody who may be overweight. They may not yet be pre-diabetic. So it's important to call out that difference where diabetes prevention programs are truly focused on individuals that are not yet diabetic, but have been diagnosed with pre-diabetes. And so for Kaiser, that program that services that population is OMADA. The weight management vendors for Kaiser Permanente. So these are the individuals who aren't yet diagnosed as pre-diabetic. The partners that support those are OMADA, Weight Watchers, and Kaiser's weight management program. And then for individuals that have been diagnosed with diabetes, the Kaiser Diabetes Management Program supports that population. And then Kaiser also has general lifestyle health coaching, and we'll talk about that program as well. For those with MODA as a health plan, it's different if you're in OWEB or PEB, the program that addresses diabetes prevention. For OWEB, there's MODA's Pre-D program. And for PEB, they have Livongo. Livongo is also now named Teladoc, so we have it Livongo as Teladoc Health. But if we're still calling it by the name that most people know at this point. But just to be clear, it is now entirely branded as Teladoc. So if you see that moving forward, that is how they are going to market with their product. Weight Watchers is also the weight management solution for those under MODA. And then for individuals living with diabetes under MODA, they have a choice between Livongo and Virta. Also, general health lifestyle health coaching is offered by MODA. And then finally, Providence is offered to PEB members. We see OMADA here again, that Weight Watchers again for individuals who are overweight and obese, and then Virta for helping individuals manage their diabetes. So with all of that, we'll look into the performance of each of these programs to orient the group to what we'll be looking at as we move along. Great, move to the next slide. What we did in this evaluation that you'll see coming up, we're really at this second stage where, as I described before, we requested data from the carriers on these partner programs, and then assess the current solutions against the treatment spectrum and how they're performing. You'll see the various categories in the assessment include engagement utilization, so how many individuals are actually participating, what their experience is with the program, looking at health equity, and then also looking at clinical and operational outcomes. And then we did throughout note and effectively score how the solutions performed by color. So you'll see that if they get a green, they're performing as we would expect them to. If it's orange, it's average performance. There could be some gaps though, however. And then red indicates significant gaps in the performance. So something that we kind of have concerns over how they're overall performing. And there are some cases where the data wasn't provided. So we can move forward. All right, now we're getting into the actual results. You're probably chomping at the bit, friend, wanting me to move on to the actual results by now. So we definitely wanted to orient the group to what we were seeing. So we'll jump in here and get started. So some key themes across all the vendors that we looked at, there were definitely a lot of variations in their performance and their overall impact. Some really key findings, though, really applied to all of what we looked at. In general, I would say we had challenges in really collecting the right data to actually make some informed recommendations. You'll see throughout that there are gaps in some of the data we were able to collect, some inconsistencies, some challenges in comparing to book of business, so not necessarily knowing, or benchmarks, and so not necessarily knowing if the numbers are good or bad because benchmarks weren't able to be provided. So in general, some challenges in collecting that data. We also noticed, you'll recall on the slides a couple slides ago, with the number of vendors per carrier, that even for the same vendor, there was some variation in outcomes among different carriers. So under different carriers, the vendors are having different performance in some cases. And we'll get into that as well. So it's hard to generalize in a lot of cases. We got fairly limited data on the satisfaction metrics to understand member perspectives. And then also we've noted broadly, and Katie will speak more about this too, about there's opportunity for stronger vendor support of priority populations given the known health disparities within the PEB and OWEB populations. Okay, we can move on. All right, so for our first category, diabetes prevention. So I will give a quick overview of the data insights themselves. These are all, we started each section with a roll-up of what we noticed for each of the programs that apply to this specific condition area. And then we will dive into specifics for each of them on subsequent slides. So we will get much more specific into the actual data as we move through this. Before we get started, though, just on the slides we've covered thus far, are there any questions so far, or are we ready to jump in? Okay, not hearing any questions so far, so oh, yes, I do. Hi, Bill.
Hey, just a quick question, because I didn't pick it up, but when you say meeting expectations, would we consider like maintaining the person's A1C and diabetes control as meeting expectations, or is improving expected?
Generally, improving is the goal for these programs. I mean, A1C isn't the measure for all programs. That would be the measure for pre-diabetes and diabetes. So, I mean, generally, we would hope individuals improve their A1C by participating in these programs. And we do have oh, go ahead, Bill.
I was going to say that's the level of the tough green, so to speak.
Yeah.
Got it.
Yeah.
Thanks.
And you'll see more of the rationale for those as we move along, the green or the red. All right, I'll jump in. So OMADA, you see OMADA is provided by Kaiser and Providence. As I alluded to on a prior slide, there was fairly limited ability to report on the metrics that we proposed and that we asked them for. Enrollment's generally fairly low, around 4 to 5% of eligible members. Again, I mentioned that benchmarks were challenging. Benchmarks is something we're going to ask for moving forward, or more, more insight on benchmarks. But the member satisfaction was good, 75% plus member satisfaction. And then the benchmarks they were able to provide, there was above average participation in coaching at the 6-month mark. So members were sticking with the program. Overall, though, this points to the challenges with consistency from carrier, that Providence members on average had poor satisfaction with Omada at 68%. Kaiser members were more satisfied with Omada, 75 to 85%. Omada also, on the health equity side, indicated some support for members who do not speak English. We'll get more into the specifics on all of these metrics in the subsequent slides. And then overall, their weight loss outcomes are below the benchmarks they were able to provide. The quick summary of this is a preview slide, by the way. Like I said, we'll have all of the specific data on slides that follow. Under Teladoc or Livongo, enrollment's really similar, and this is provided by under MODA for the PEB population only. Enrollment's similar to Omada at 5 to 6%, but unlike Omada, there was very low utilization of coaching sessions at 6 months at 6 months into the program. So 0.5 coaching sessions for members, which is very low. So showing a pretty significant drop off of membership as they moved along. There was also very limited health equity data that we were able to collect. They did indicate there was some support for Spanish-speaking members. So there is a little bit, but still more that we would want. The couple of challenges, and again, when we show the detail slides, we'll be able to show some of the results here. That two main things under the Teladoc program, and this is for diabetes prevention. So one of the measurements was body mass index. And there was no clear reduction in body mass index and reduction over time. And then there were actual increases in members in overweight and obese categories over time, and it roughly doubled over 2 years. So the outcomes aren't tying, because ideally we would like to see reductions in weight and BMI in a diabetes prevention program. Also, in general, a lot of the outcome data is fairly incomplete. Satisfaction results are very variable, very, very low respondents. And we would really want to have more individuals respond to satisfaction to understand how they're perceiving the program. All right, and then finally, the pre-D program that's offered by MODA for OEB only. It's a lot lower enrollment in this program. It's about 1%, but actually that's by design. It's a small cohort approach, and really those that enroll tend to stay engaged in it. So MODA only does take certain cohorts of the population at a time, and so that engagement number will likely be pretty low because of the acuity that members they target. They were able to report on a lot of the clinical outcomes we asked for, but the results were mixed. They also aren't able to provide benchmark information because OEB's the only client for this pre-D program. So to actually compare benchmarks of how the program is performing for others or in general was challenging because OEB's the only one that uses it. So you are the benchmark. So it was difficult to see what that is. And again, we'll get into some more of those results in a minute. And then they also had some limited abilities to report health equity data. Members, though, will be matched with some Spanish-speaking coaches if their preferred language preference is Spanish. So that's a good thing about the program and the health equity piece. All right, there is the overview. I'm going to turn it over to my colleague, Kalia, who's going to dive into the specifics of each of these findings.
Thank you, Rob. Next slide, please. So while Rob provided a high-level overview of our findings, the rest of each section for vendor and type of program, so DPP, diabetes, etc., gives us an opportunity to do a bit of a deeper dive. There is a lot here, so before we dive into it, for each carrier and vendor, we have data from 2023 to 2025. We requested data on enrollment, engagement, demographics, health equity, and clinical data. And while we did request the same data from all carriers and vendors, That variability that Rob mentioned earlier is a key theme, and I just want to reiterate it because it will continue to come up throughout as we look at the data. And this exercise also revealed the need for direct communication with vendor partners who are providing the data, as we got most of this through the carriers. So despite conversations with carriers, the approximate eligibility metric that you see here is based on plan enrollment and CDC prevalence data. So about 30% of people in the US are pre-diabetic, so we use that metric to come up with the eligibility here. Although the metric on the right is highlighted in green, a sustained coaching engagement at 6 months remains low across years, but is slightly above book of business. We also see that the benchmarking for activated participants for WMATA is 93%, and Kaiser and Providence demonstrate being at or just slightly below benchmark throughout the years. For average months in the program, there are quite a few data points throughout which are not reported on, whether for either being because they are a custom data point that need to be discussed directly with PEB and OEB or just not being available. But we do indicate that throughout. So in this case, for average months in the program, this is a data point that WMATA was unable to provide. And when we asked for a number of enrolled participants who were inactive while monthly fees were invoiced by the client, KP indicated that this was not applicable to the WMATA program. Next slide, please. So this was also part of the high-level overview that Rob just did, but across the board, participant satisfaction is averaging about 76%, with Providence members consistently having lower satisfaction compared to those who are enrolled through Kaiser. For each program, we also requested health equity data, including information on language availability, provider search capability, and how they address or plan to address any unintended consequences that may arise or inequities that are identified within their program. So members enrolled in WMATA's DPP program are primarily female, aged 25 to 44 and 45 to 60, and in the range of the BMI range of 30 to 39.9. We have some additional data on the next slide to demonstrate that. WMATA was not able to provide data on the demographics of their providers. They did indicate that it was available internally, but not available to share externally at this time. They indicated that the program is available in both English and Spanish for members, and translation services are available for those whose primary language is not English. They do not have any provider search capabilities at the moment, and it is not on their roadmap. And as far as unintended consequences and improving disparities, WMATA has a health equity committee, as well as a dedicated role for health equity strategy and implementation. They also have an WMATA Insights Lab to leverage data analytics to reveal trends in social determinants of health and identify any opportunities for intervention. Next slide, please. This slide just demonstrates the demographics of enrollment for the diabetes prevention program through WMATA, and our 2025 year-to-date data for this program is through June 2025. So we do highlight the enrollment by age. This mostly female, mostly white, as I mentioned on the previous slide. Next slide. A number of clinical metrics were requested for this program, but could not be reported by WMATA due to them being custom, as I mentioned earlier, or not applicable to this program. For this, we're showing percentage of participants losing 5% of starting body weight at both 6 months and 12 months, with WMATA's benchmark for this metric being about 46%. So we see across the board that there are some significant gaps in performance for both OEB and PEB, as well as Kaiser and Providence members. PEB Kaiser does consistently have the highest percent of participants who are losing 5% of their starting body weight. And Providence shows stronger gains between 6 and 12 months compared to the gains from 0 to 6 months on participants losing 5% of their starting body weight. And now I will pass it over to Katie to talk through Teladoc and Modus PD prevention program.
Thank you, Kalia. Okay, so you'll see the format is similar to what Kalia just talked through. So we'll have the same format for the next number of vendors we talk through. But here, we were just talking about Omada. We're now switching gears to Teladoc Livongo, their diabetes prevention program, and this is only offered to PEB members. So again, you can see here we've created the total approximate eligible 18 and over based on health plan enrollment with CDC prevalence data, as Kalia mentioned. So that's where we got the number across the top for those who may be eligible, as opposed to those total members enrolled. And you can see, again, similar enrollment to Omada's program, around that 5 or 6% on average over the last 3 years. Their total activated participants is higher than Book of Business benchmark that was provided by Livongo. Teladoc, you can see that on average it's in the high 90s. So we notated that as green. Where we do see room for improvement, they did not provide a Book of Business benchmark, but given the data, we felt confident putting this as highlighted as a red, an area of opportunity in terms of the average number of coaching sessions per participant. We see on average across the 3 years, less than 1 coaching session at the 6-month mark and the 12-month mark, indicating that people really aren't speaking to coaches, and maybe they're seeing a coach maybe once in the beginning of the program, and then that drops off. And then the average months in the program has changed year over year. It started as about 7 months on average back in 2023, but as we get closer to 2025, folks are staying in the program longer. If we go to the next slide, we will see some of the member experience or participation, satisfaction, and health equity data for Teladoc Livongo. So we were provided that the benchmark for satisfaction is they gather that through an NPS score. The benchmark for their Book of Business is 60. So you can see over the last 3 years, still below Book of Business data. In 2023, it was particularly low at -13. By 2024, it was 50 and then went down again to 40 in 2025. I think the other important piece of information here is while there were a few hundred eligible participants to take the survey and give their feedback, a very, very, very low number were willing to respond. So, you know, again, it's an area of opportunity to get more feedback from members, but in addition, you know, the more data we get back and more survey responses, the more, you know, informed and rich that NPS score is as well. So we certainly see opportunity there. In terms of information to support health equity from a vendor perspective, similar to Omada, it was mostly white females who were engaging with Teladoc Livongo, between the ages of 50 and 69, living in urban areas. And we do have additional information on the next slide. It was an interesting data point to see that about 20% of members engaging in Teladoc Livongo were considered to live in rural areas. So we see that as a positive in terms of trying to reach members who have additional, you know, access to care needs and being able to utilize the virtual nature of this program. So that was a positive. They did not have information or any data available on the demographics of providers. They did provide some information about support for Spanish-speaking members. They have English and Spanish as options. They did note that there was only 1 reported user who requested Spanish services such as device checking, self-guided materials, etc. So that was available to them. And that if the preferred language is Spanish of a member, they will automatically be matched with a Spanish-speaking coach. If we go to the next slide, similar to what Kalia shared, and we'll have this for most of the vendors if they were able to report it. This just shows a highlight of, again, those enrolled in Teladoc Livongo by language, age, gender identity, race, ethnicity, and rurality. So we highlighted the rows in which there was the greatest prevalence for each of the categories. If we go to the next slide, we then have clinical outcomes for Teladoc Livongo, which you can see we rated as having significant gaps in performance. This bar graph you see in front of us is data related to member BMI progression. So the highest level, ideally, as you all might imagine, you would hope that those lines would be going down instead of up. Each of the different colored lines are related to different categories of BMI, as you can see on the legend kind of towards the right of the graph. So for the most part, we're seeing those lines go up, indicating that there's actually an increase in BMI over time, and we would want that to go down. So, and some of the other data here we have around number of coaching sessions and how that correlated to average percent weight loss. So there's a much higher number of members who, if we're looking here on the right of these three charts, higher number of members who have 0 coaching sessions, 0 or 1 coaching sessions. As we get closer to the higher numbers, the 3+, you see the average percent weight loss goes up quite a bit, but the number of members is much lower. So certainly an area of opportunity to have, Teladoc Livongo encourage that coaching participation for increased engagement in the program. We can go to the next slide. There's a couple other clinical operational outcomes. We asked about a number of outcomes measures. They're actually all listed in the appendix, but for the purposes of what a vendor was able to provide or not provide, we didn't necessarily show it at all. So here, some of the other metrics we looked at around percentage of participants who no longer met prediabetes criteria within the program year. So again, that is looking to understand if a member is enrolled in your program, are they reducing their BMI? Are they getting healthier to no longer meet that prediabetes criteria? Looking to understand the number and percentage of participants who developed, so on the flip side, who ended up developing type 2 diabetes within the program period, and then average change in starting blood glucose or HbA1c levels. So again, showing that Teladoc Livongo was not able to provide these metrics. Omada was not either, but this gives a little bit more insight into the types of outcomes measures we were looking to collect from the vendors to be able to evaluate their performance. Okay, if we go to the next slide, I think this will switch gears into MODA's pre-D programs. This is our last diabetes prevention program we'll look at before looking at the weight management program. So again, this is only offered to the OAB population, and there were no benchmarks that were able to be provided, as Rob mentioned, just because it's actually only offered to OAB members at this time. And you can see here the total numbers enrolled is low compared to Omada and Teladoc Livongo, but that's actually by design, that it is a smaller sort of cohort model that MODA has created, and it is, the members sort of stay together through the program. They have regular coaching sessions, and it really does foster, although a smaller number of people that are being touched, the people who are engaging in the program are staying engaged, given the kind of unique makeup of this program. So smaller number of enrolled, but you can see at the 6 and 12 month mark of coaching sessions, at 6 and 12 months, folks on average are engaging at least a couple times a month at the 6 month mark, and close to that by the 12 month mark. And on average, members are in it for about a year, a little over a year. If we go to the next slide, we'll look at some of the satisfaction and health equity data. So for participant satisfaction, it's a little bit mixed in terms of the data that was able to get collected. For 2023, there wasn't a survey administered. By 2024, there wasn't specific scoring that was included, even though there were 79 members who responded out of 82, which is a good, denominator. And then, or numerator rather, and then in 2025, there was great satisfaction. About 95% of members were either satisfied or very satisfied with the program. So that is a positive. It's just really only data we were able to collect for last year. In terms of health equity data, the enrollment has slightly declined and concentrated among older members, primarily ages 50 to 69. Majority identify as white, female, and Hispanic is the next largest group. And I think we have data on the next slide related to that. So as you can see, there's sort of a theme here with some of the data that's being able to be provided in this section. Not able to have reported demographic of providers. Languages available are English and Spanish, but it's unclear. It was noted in separate materials we found that there is some language capabilities and translation services outside of English and Spanish, but they appear to be limited. But again, more support for Spanish speakers. The entire platform is offered in Spanish along with English, and they'll be automatically matched to the Spanish speaking coach if that is the language selected of preference. We go to the next slide. Yes, so similar looking slide again in terms of demographic information and where we see the majority of members engaging for these different demographics. All right, one more slide. Okay, so and Rob had covered this, but you can see here a number of clinical operational outcomes listed here on the left. So this showing more of this because MODA's pre-D program was actually able to provide quite a bit of data. So again, we highlighted some areas we saw as maybe some areas of improvement or opportunity versus where there's maybe average performance with some gaps without benchmarks. But we saw there was an improvement over time, over the years, of the percent of participants who lost less than 3% of starting body weight or gained weight at 6 and 12 months. So we saw an improvement in those numbers. We would want those numbers to be low, right, for those who gained weight at 6 months. We want that number to be lower. But those percent of participants losing 5% of their starting body weight at 6 months and 12 months, you can see here range anywhere from 10 to 20% over the 3 years. If we go to the next slide, they had they were able to provide us with some, which is a lot here. We recognize that, and we have a couple call outs to help guide your eyes, but this is really looking at the average percent of starting body weight lost relative to the number of coaching sessions. So is there a correlation between number of coaching sessions and the percent body weight loss, which we saw a little differently with Teladoc Livongo. So some of the call outs here is around there were some people who dropped out early, making early attrition the main limit on program impact. And also participants who completed more sessions showed greater average weight loss, which again, we would anticipate that those who were engaged and had multiple sessions with a coach, the more likely you're going to be successful in the program. Okay. I think that might be it. If we can move forward to the next slide. Oh, there's one. Okay, there's one more slide of clinical data. Okay, so some of the other metrics we looked at, number and percentage of participants who developed type 2 diabetes within the program period. This is where we saw a little bit of mixed results, is having about a 10% on average participants who still develop type 2 diabetes is not really high, but a little bit higher than we'd like, and that's why we have it noted in yellow. And then you can see the average change in blood and starting blood glucose or HbA1c levels listed here as well. So again, no benchmarks to compare against, but it was meaningful that MODA was able to provide this data to us. Okay, any questions from the group? I think that wraps up our pre-diabetes section before we move into weight management. All right. Well, Rob, I'll hand it back over to you to talk through the next section.
Thank you.
All right. We'll advance to the next slide. All right, so just like the prior section, we've arranged this where we'll give you all the spoilers first, and then we'll talk about the specific detail later. So here's the quick overview of this section. And as you'll recall in the opening slides, Weight Watchers is a program offered across Kaiser, MODA, and Providence populations for both the applicable OEB and PEB populations under those health plans. Weight Watchers has a lot of engagement. Most people are engaged in more than one activity. It's also a very well received program. Many individuals like participating in the program. And so, it does have some credibility within the program, within the population as a whole. So high engagement, good satisfaction. However, the number of individuals who did record and lose a certain amount of weight is overall fairly low across the various carriers. They also, they were able to provide the data we asked for on clinical outcomes. However, the metrics themselves don't necessarily correlate to clinically significant results. Also, they really didn't provide much in the way of health equity data, except did indicating some support for Spanish speakers. The OMADA program, which is the weight management program offered to the Kaiser population, similar to the prediabetes population, had low utilization since they were launched. They were also unable to provide a lot of the data, and only one clinical outcome metric was provided by OMADA. Also, a lot of the health equity data wasn't provided, and they noted it was not on the roadmap. And then they also didn't provide benchmarks because the PEB and OEB book of business is the majority of their book of business for this distinct program with Kaiser. I mean, it is important to note, though, I think, as we move forward on all of these, I mean, these are all national vendors that are subcontracted with the specific carriers. So they do have broad books of business in all of these in their commercial business. So we do want to note that, but these acts were specific to the offering that's available through the various carrier. And then there is also a weight management program offered specific to the Kaiser population. This had consistent enrollment, about 5% year over year. Again, limited data provided here. That low data on the average number of coaching sessions and demographic information, also some very limited health equity data collected. They also weren't able to provide any clinical outcomes metrics or member satisfaction metrics. So we didn't really collect much weight management information for the Kaiser population in general. All right, any questions before we get started in this section and diving into the details of each of these? All right, Kalia, I believe you're up next.
I think it's me, Rob.
Okay.
All right, so Weight Watchers, you can see here there's many columns because it's offered to everyone, right? And all carriers, both OEB and PEB. And there's a lot of green here. We were able to get quite a bit of data from Weight Watchers, and they did provide some benchmarking as well, although not necessarily on the slide. But this is a program there's not necessarily criteria that needs to be met, like the prediabetes program we talked about. It's open to anyone over age 18. So the total eligible number is pretty high. And the total enrolled members is actually, on the higher side as well. You can see particularly high enrollment called out for Providence members, PEB Providence members. But otherwise it's about 10, 11% on average. The total activated participants, which means they completed at least one activity, again, doesn't necessarily mean that they were, stayed engaged in the program over time, but it's a good data point to understand, did someone just sign up and set the phone down or not do anything, or did they actually report a wait or participate in a program? And so you can see that the total activated rate is quite high as well, in the high 90s.
I asked a question real quick, sorry.
Yeah, sure.
So my question is, the total activated participants, why was the benchmark set at 1? Or maybe the better way to phrase the question is doing one activity a good benchmark or not?
So it's a good question. So it wasn't necessarily the benchmark provided by Weight Watchers, but yeah, it's a way to understand, because a lot of times we look at who enrolled in the program, right? And so that's just kind of signing up, but not doing anything. This tells us that difference between the two rows is we understand who actually signed up for the program. Not 100% of people actually then started to engage in the program, but a pretty high percentage do. And then we have on the next page, when we ask about things like average months in the program or coaching participation, that helps us understand those smaller subset of members that not only enrolled, they completed at least one activity, but then they are actually engaging in the program regularly, if that makes sense. So we've asked it through a few different lenses.
Yes.
Okay, great question. All right, well, let's look at that data then. If we go to the next slide, I know there's some additional engagement utilization information. So here's another one, the number of active participants who completed all prescribed program requirements. So still a quite high number, right, in the mid to high 80s. So a good number of people are still engaging with the program, you know, and Weight Watchers kind of definition, completed all prescribed program requirements. Where we see some opportunities around the coaching sessions at 6 months. It's a little different with Weight Watchers. They reported it as workshops per member. So understandably, every vendor is probably going to have a little bit of a different angle on some of these responses just because of the makeup of their program and how their program is administered. But overall, you can see on average, members are having workshops, you know, within a 6-month period, about 2 to 3 times. So that means maybe once every 6 weeks or so, or once every couple months. So not a lot of kind of workshop engagement amongst members. But the average months in the program, this is kind of on a rolling basis. You can see these months numbers are quite high, but members are staying in Weight Watchers for multiple years. If we go to the next slide, we will look at some of the satisfaction numbers. So the challenge here was some of the data collection from Weight Watchers. So they weren't able to share actual satisfaction numbers with us, or there were no responses to report. So while they have a really high number of people who enroll or maybe even engage in the program, very, very few people are actually completing surveys to give their satisfaction feedback. So it's hard to evaluate. If we go to the next slide, we can look at some of the health equity data, which we really see as a significant area of opportunity. You know, sometimes you sort of read between the lines, if you will, with what's provided in terms of saying, you know, no, we don't have this information, but it's on our roadmap, or no, but, you know, it's housed internally. You know, still areas of opportunity, but for a lot of what Weight Watchers provided, it was just, no, we don't have it. No, we don't collect it. For demographics of members engaging, which I think every other vendor was able to provide, the demographics of providers or their provider search capabilities. They actually didn't provide it to us in this format. We found it through, you know, some of our own research or other materials we've seen from Weight Watchers. But they did, we did see that they do have some support for Spanish-speaking members. They have virtual workshops that are conducted in Spanish, a dedicated Spanish customer support line, a Latino community group accessible within the app and social media platform. So it was really good to see that that was something we were able to add in here. But certainly see this as a significant area of opportunity given a lot of their responses. Where they were able to provide a lot of data, which were mixed results, were in their clinical outcomes. So I think over these next few slides, there's quite a bit of data, but we try to provide some call outs wherever possible. So if we go to the next slide, Weight Watchers is able to share with us the average weight loss across members for 1 to 6 months, 7 to 12 months, 13 to 18 months, and 19 to 24 months. So a couple of call outs here. So across kind of all years, all carriers, short term, the 1 to 6 month average weight loss is similar and consistent at about 3 to 5%, indicating comparable early effectiveness across OEB and PEB vendors. By 2025, and several cohorts, mostly for Kaiser and Moda, they are showing larger sustained weight loss, about 5 to 7% by the 13 to 18 month time frame than in prior years. So we're not sure what, but it does suggest recent program or cohort changes are driving stronger midterm outcomes. And then looking at the top here, although PEB members generally outperformed OEB in 2023, the 2025 results narrow and reverse that gap, implying recent changes improved with OEB performance, or that 2025 cohorts differ materially. So I know there's a lot of numbers here, but trying to make some call outs here around, we do see some slight changes over time, but generally we're seeing around the same amount of weight loss between, month 1 and month 24. If we go to the next slide, we'll look at some additional data points related to outcomes. And this is where their benchmark information came in. So we looked at data around, and you had seen some of this from the pre-diabetes outcomes, but we looked at, what or members who recorded at least one weight loss and lost between 3 and almost 5% of their starting weight. So that's a good, helpful indicator to know people are engaging in the program. They're recording at least one weight and they're losing about 3 to 5%. And then we have it on the next row is recording at least one weight loss and lost between 5 and 10%. And then on the bottom row, recording at least one weight loss and lost 10% or more of their starting weight. And across the board, there is some yellow here, but almost across all years, all carriers, we see members below book of business benchmarks for Weight Watchers in these areas, right? So their benchmarks are called out here on the left. For this first row, benchmark is about 6%. It goes to about 7.5%, and then 5.5% on the bottom row. So although there are a lot of members enrolled in the program and we saw really great engagement, where we see lots of area of opportunity is that there's not very many people who are actually reporting at least one weight loss and actually losing weight. So this is really key here in terms of outcomes with this vendor. If we go to the next slide, we have a few additional data points as well and some more benchmarking. So the percent of members moving down in BMI or staying in a healthy BMI, we would want this number to be high. We'd want to see most people moving down in BMI or at least staying in a healthy BMI category. And again, they're below benchmark across all years compared to Weight Watchers. And a large majority of members maintain their BMI category, with PEB Moda being the highest. So again, that's indicating that people are enrolling, they're engaging in the program, but there's really not a lot of outcomes and positive change in BMI. And in fact, if you look at this last row, the percent of members who gained weight and increased their BMI, the benchmark for Weight Watchers is 5%. There is, sort of at benchmark across the bottom. As we get to 2025, we do see it trending down, which is a positive. And there are other data points indicated that by 2025, there was some positive change as well. But that's, again, wanting to see that number be quite low in terms of those actually increasing their BMI and gaining weight. All right, I think let's go to the next slide and see what else we have here. Okay, so that wraps up for Weight Watchers. Lots of data there. I think that might have been the vendor with almost the most data. So if there's any questions, please chime in, but then I'll hand it over to Kalia for the Omada.
Thank you, Katie. Well, if there are no questions on Weight Watchers, the data that we have available for the Omada Weight Management, very different from Weight Watchers, is very limited as it launched January 1st, 2025. But from the data that we have available since its inception, it appears that participation has been pretty minimal so far. Of activated participants, though, at least 90% are completing at least one activity. The program indicated that they don't have any prescribed program requirements, so they were not able to provide us any completion data on that front. Average months in the program, they indicated, would be a custom data point, so they didn't provide that either. And Omada was unwilling to report on number of enrolled participants who were inactive while monthly fees were invoiced based on Kaiser's billing model. If we go to the next slide, we'll see that data on member experience is simply not available due to the very small enrollment numbers and small sample size, as well as the recency. It just started about a year ago. Additionally, Omada uses a 7-point scale compared to the 5-point scale that we requested, but we don't have the data now to compare. And capability to report on referrals will be live later this year, according to Omada. On the next slide, we have health equity data, and as Rob mentioned, there was only one clinical outcome metric that they were able to provide. So we did go over the health equity data earlier as we talked about Omada's diabetes prevention program. So it's just pretty much what we discussed earlier. The demographics do vary a little bit, with enrollment being mostly employees who are white, female, ages 25 to 44, followed by 45 to 60. When we look at the clinical outcomes on the bottom, we are seeing that 27 and 40% of members in OAB and PEB, respectively, are losing 5% or more of their starting body weight at 6 months. We do not have the data on 12 months due to the fact that it was just launched 1/1/25. On the next slide, we have the demographics data slide that we have for all vendors. And while enrollment is low across the board, we do have a call out here because it is significantly lower for members of racial and ethnic groups who are not white. So it raises the question for us if whether Omada is reaching the right populations, given what we know about disproportionate prevalence and disparate health outcomes for those with prediabetes and diabetes in certain racial ethnic groups. But again, it is early in this program, so more to come. I believe that's all we have for the Omada weight management. So are there any questions before we go to Kaiser's weight management? Okay, switching gears to Kaiser's weight management program. So their enrollment is consistently above Kaiser's benchmark of 2.9%. And they also indicate that the members completing prescribed program requirements is the same count of members who are enrolled. So both of those metrics across the board remain high, above the benchmark of 2.9%. Kaiser was not able to provide unique member counts for encounters with the program, but it was able to provide a count of total member encounters. So it's a count of each time a member indicated, but it is not the count of each time a unique member indicated, meaning one member could be counted multiple times within this metric. With data on average number of coaching sessions at 6 months, it generally hovers around 1, with the benchmark being 1.1. So we see it ranging from 1 to 1.2, which was highest with PEB in 2023, but ultimately about or around benchmark. And they were not able to provide data on average months in the program at this point. We also were not able to collect any data on member experience. They did not provide it and do not intend to provide it at this point. The next slide, some of their health equity data, which is very limited. So while we do have demographic data, similar to Weight Watchers, this is absolutely a significant area of opportunity for Kaiser. We have it rated as red with some significant gaps in performance. They were not able to provide provider demographic data, do not have provider search capabilities for this program, and did not report how they plan to address any unintended consequences or inequities that arise from the program. When we asked about languages available, they indicated that there is a line interpreter service available for members, but did not indicate what languages the service is available for members. And they were not able to report on clinical metrics as we requested. And on the next slide, we have the breakout of demographic data similar to the other programs, just highlighting what I already captured on where members are located, the enrollment being primarily female, white, and ages 19 to 44. And I'm going to pass it back to Rob if there are no questions here to talk about the diabetes management programs.
This is Kimberly. So when a program, I want to wrap my head around a little bit around the metrics that we're looking for, the demographics that we're looking for, the answers to the questions. So when a program is built, do they almost need to pre-build the answers to these questions, like have it baked into their formula on how they gather data? Is that what we're seeing, where if a program's already up and running and it is live, then there's data that they can't because they didn't get it in the beginning? Is that where we see the problem lies? Or I'm just trying to wrap my head around it. I've built programs before, through Oregon Department of Corrections, and I know that after it leaves the barn, somebody always comes up with, it would have been great if we had known this. And the programmer's like, you missed your opportunity. You should have brought it up before. So is that what we're seeing? Not the unwillingness to provide, but the fact that they would have to do like a paper or something like that. Is that what we're seeing?
I'll take a pass at that in a couple of ways. So I think the first answer to your question is we are actually, as we are drafting second round of renewal letters for each of the carriers, we're actually asking more specific questions on data reporting so that we're sure that we're getting data in this consistent format and that it's useful and providing us the answers that we need. The other piece of this, and I alluded to this at the beginning, is a lot of the reasons are that that it's different in terms of the program design and how they're delivered via the carrier relationships than they might be on a direct basis. So there's some differences in terms of the reporting that is disseminated through the carrier ecosystem than than they would otherwise collect. So that's, again, part of the reason why we're going back to request this more specifically so that we have the data that we need to, or that OWEB and PEB has the data that they need to successfully evaluate it and see the results of the programs.
Yeah, and I'll just add, Kimberly, I think you make a great point. I think there are times where the vendor is saying, yeah, we haven't built this into our system, so we can't report on it. And now that's going to be a big effort to do that, which is understandable and okay. We asked some questions around improvements in like behavioral health outcomes for vendors who might track, PHQ-9 scores alongside knowing that, such a common comorbidity with cardiometabolic disorder, right? And a lot of vendors said we don't actually do that, and that's fine. But for some of these, there's really no reason for a vendor to say we don't have any data on clinical outcomes, right? So even if it's not exactly what we're asking, we were looking for vendors to give us some information, and that's where we see a big miss if vendors weren't able to really provide anything. Does that help?
Yes, thank you. Thank you both so much.
Absolutely. Great. All right, one more section. Thanks for hanging with us in all of this data. There is a ton, as we showed you at the beginning. All right, now we're going to talk about the vendors that are actually supporting members that are living with diabetes. So we will cover the overview of what we found with these vendors next. Okay, 3 programs here that are offered. So first, for the Kaiser population, for OEB and PEB, diabetes management is offered through a direct Kaiser program. So what we found sort of overall, again, we'll get into the detail shortly, is that there is meaningful enrollment for those who are eligible for the program. So they did see individuals that were eligible did enroll. However, again, another limited ability to provide data, mostly just things on the average number of coaching sessions and then demographic information. Also, there's a lack of clinical outcomes, metrics, health equity data, and member satisfaction and feedback. Under Teladoc, which is offered via MODA for diabetes management, they were below the benchmark they reported for program enrollment, but actually activation, meaning those individuals that actually took a step to enroll themselves in the program, was higher than benchmark. They also had provided limited health equity data, indicated some support for Spanish-speaking members. They had about a 50% response rate for program satisfaction. Overall, they collect NPS as part of their satisfaction, and it was overall low. The other piece under that Teladoc outcomes, there was actually an increase in members in the A1C level of 7 or less over time. However, the number of members with levels greater than 7 remain mostly the same. So, we didn't see a great impact in terms of lowering or maintaining A1C. And Virta. Virta is offered to MODA and Providence members. Overall, their enrollment was also fairly low. This is also sort of by design for this program because it does have a much more prescriptive approach in terms of their approach to diet, to stratification for the program, to who is eligible, things like that. But there certainly is likely some opportunity to enroll more folks in this program. They also provided limited health equity data, but some of the supplemental materials they provided indicated a really strong focus in supporting social determinants of health, also maintaining clinical outcomes regardless of socioeconomic status. You'll also see that for those that were enrolled, there was actually retention in the program. They did stay involved. And they also did show a meaningful decrease, actually, in A1C levels over 6 to 12 months, but a bit lower in other areas, medication benchmark notably. All right, to dive into specifics of each of these, Kalia, are you taking these ones?
Yes.
All right, great.
Thank you. So we'll start with Kaiser's Diabetes Management Program. So as Rob indicated, they did demonstrate strong as well as meaningful enrollment throughout the duration of the program. It remains consistent from 2023 to 2025. Their data indicated that all enrolled members were also active participants who completed all prescribed program requirements. Once again, they provided total encounters, not unique member counts, for interactions with the program. For coaching sessions, their engagement at 6 months hovers just around or a little bit below the benchmark of 1.3. We see a consistent 1 or 1.1 with 1.3 for PEB members in 2024. For member experience data, they were able to provide information on patient referrals, but not on participant satisfaction. So we rated the member experience with a red with opportunity for improvement, as there's an opportunity to provide data on participant satisfaction so that we're able to contextualize any member feedback that we received. But for the patient referral metric, you can see that referrals are declining over the years. So for OEB example, the OEB population receives 1,169 referrals to health and education and wellness services in 2023. That same metric is 802 in 2025. On the next slide, we have some commentary on their health equity and clinical data, which once again, were quite limited for this program. We have member demographic data, but we don't have provider demographic data, any information on language availability, search capabilities, or any actions they intend to take for unintended consequences or inequities of the program. So for this program, it's mostly white women aged 45 to 64 who live in urban settings who are engaged with the diabetes management program. About 35% of members are in a rural population. There's slightly higher engagement from those who identify as Hispanic within the OEB population versus the PEB population. For clinical outcomes, we do not have any clinical outcomes data for this program. It was not reported on. And on the next slide, we again have just some overall demographics data highlighting the higher enrollment with women aged 19 to 44 who identify as white, mostly in urban areas, but with high enrollment in rural areas as well. There are no questions here. Then we're going to turn to Teladoc/Livongo Diabetes Management Program through MODA. Okay, so eligibility for this program was based on prevalence data from the American Diabetes Association. So once again, it's a bit of an estimate. So the benchmarking for enrollment was about 25% for this program, and we're seeing enrollment for this population consistently below that across the years, ranging from 13 to 15% enrollment. The total activated participants remains consistently above the benchmark of 85% for Teladoc's book of business. We see it ranging from 92 to 95%, staying consistently high across the years. And the average number of coaching sessions hovers around 1. We do see an increase for year-to-date 2025 data for PEB at 2.3 sessions. There's also a bit of an outlier with 6.6 in 2023 for PEB, but overall averaging around 1 to 2 coaching sessions at 6 months. They were able to report on average months in the program, ranging from 17 to 30 months in the program. Next slide. So we do have the data for member experience and health equity data. We did rate the member experience as a red with some opportunity for improvement and significant gaps in their performance. So this program is not referring members. There's no patient referral data to collect, so we don't have any reporting on that. Overall, participant satisfaction remains relatively low. There is one outlier in 2025, but that is based on one respondent who rated the program 100. So that is not exactly a valuable metric, but it is consistently low, and there's absolutely opportunity to figure out why this is so low and how it can be improved. Their reporting on health equity data also is relatively limited. The members do have the option to choose a specific coach for follow-up visits, but they don't indicate any provider search capabilities to support provider concordance. When we ask about language data, they do say they support English and Spanish, and that Spanish-speaking members will be matched with Spanish-speaking coaches. So we rated their health equity section, and as average performance with some gaps, there are some highlights. Members engaging are primarily female and between the ages of 50 to 69, living in suburban areas, and they did not report on any unintended consequences or inequities and how they may plan to address those. And on the next slide, we once again have that breakdown of demographic data for the Livongo Diabetes Management Program with members primarily ages 50 through 69 engaging, white members, and mostly suburban. And on the next slide, our clinical data for this program was limited, but Teladoc was able to report on members' HbA1c progression. So for their book of business indicated a 1-point decrease in estimated HbA1c. So on the line chart that you see on the bottom, 2023 is all participants who are at the start of the program. 2024 is the measure of those same participants after 12 months of the program, and 2025 is from 24 months of the program. So while the data is relatively limited, you will see that there is a slight increase in the number of members whose A1C drops below 7 with that blue line at the top. There's no questions or anything to add here. I'm going to pass it to Katie to talk through Virta.
Thank you, Kalia. Okay, so this is Virta's diabetes management program that's offered to both OEB and PEB through MODA and Providence currently. So it wasn't put in place until mostly 2024. You can see Providence, it was in place in 2023. A lot of the responses from Virta in terms of average coaching sessions and those who completed prescribed program requirements, their note was it's really hard for us to provide this information because the program is so personalized to members. There's not really a set of standard program requirements. So this gets a little bit at your question, Kimberly, around, they weren't really able to provide it because it's not quite how the program works, which is, okay, because they've provided some other data. There's strong retention for those who do enroll in the program, but you can see across years, the members total enrolled is very low, about 1% on average. It does pick up to 2 and 3% by 2025 for PEB members. But their benchmark is anywhere between 10 and 20% of enrollment. So we certainly see this as an area of opportunity. But again, for those who do enroll, there's very strong retention, and we have some outcomes as well to share. So if we go to the next slide, before we get to the outcomes, there is some information around, this still continues with this is a little bit, again, some different data that provided us some of the member retention. So you can see high at 90 days versus 180, 270, and 365 for OEB versus PEB. The numbers stay, they're highest for the first 90 days. They stay similar until, close to a year. And then by a year, it drops actually to 46% for PEB and 61% for OEB, but strong retention leading up to that end of the year. So on the next slide, I think this is where we have the satisfaction data. Okay. So again, they weren't able to report, they don't have any formal referral processes in place, but they were able to provide satisfaction. Again, these are low numbers, but for the majority of who did respond, they were satisfied in the program. In terms of health equity data, there wasn't enough enrollment to split out outcomes by demographic information, so an area of opportunity to see that information in the future is ideally enrollment ticks up. They don't track the demographics of providers, but members can request preferences in a coach, and Virta will work with the member to find a coach that fits their needs. They support both English and Spanish. About 1% of those who engage requested Spanish, so that was available to them. And they do not have provider search capabilities at this time. I will note it wasn't included in their materials, but as Rob had mentioned earlier, Virta has had a lot of published information about their support for and their tracking of outcomes amongst looking at folks, whether those who engage live in a rural area or suburban area, or look at socioeconomic status, and they have some really interesting outcomes around no differences in outcomes no matter a member's background. So they didn't, I don't think they could have done a better job sharing that in this section, but I just will note that in some of their supplemental materials, we were able to see they do have a real focus in health equity in other ways from what's provided here. Okay, so I think if we go to the next slide, we'll start to look at some of the outcomes data. Oh, this shows some of the enrollment data. So they were able to provide some, but you can see it's overall very low numbers and pretty limited. But if we go to the next slide, we can look at some of what they provided for their outcomes. So a little bit of a different format, but we rated them as a green, performing as expected, which means they're doing what we hope they're doing, which is seeing member reduction and member A1C progression. So this shows year over year for PEB and OAB members, they are meeting the Book of Business benchmarks in terms of the A1C reduction, and across the enterprise members with type 2 diabetes, they're achieving at least a 1.0 average decrease in A1C and an 8% weight loss. So really positive for VER to be able to report on these outcomes and also have the outcomes be, what we would hope to see. If we go to the next slide, I think there's a few more data points. Okay, and this was one of the ones I was mentioning, if track the number and percentage of participants initially identified with elevated anxiety or depression who measurably improved during the program. This, Verda noted this is not applicable for our program. But what they do have information on is the percentage of participants who have successfully reduced their diabetes medications after 6 months in the program. Really meaningful data point. The benchmark is 44. Across the years, we do see below Book of Business averages here, closer to mid-20s, mid-30%. We do see for Providence a higher, closer to the 44% at about 41%. But overall, still, trending in the right direction. Okay, I think with that, we are going to go through our last section, which is the general lifestyle management coaching. So I will hand it back over to Rob.
All right, go to the first slide in this section. And this one is much more, much quicker. So we're almost to the end, almost to the punchline for this entire section. So, all right. So as I mentioned really early on, if you still remember, both Kaiser and Moda offer broad-based lifestyle coaching to members. And so these are just programs that members can engage in if they want to improve some kind of their lifestyle risk. And so they're broad-based, not targeted at any one kind of risk factor in particular, like some of the other programs are, but they're still really important programs to note, that provide members some kind of opportunity to actually work on lifestyle-related conditions, of which many of them are tied with the subject matter we're talking about today. You'll see, so in Kaiser, there was limited ability to provide data, mostly on those that were enrolled. Average number of coaching sessions, demographic information, health equity data, also no clinical outcomes metrics for this population. However, those that did respond to satisfaction surveys indicated that their satisfaction was strong. Similarly, Moda, limited ability to provide data here, also no clinical metrics reported, and strong satisfaction. So pretty consistent results by carrier for these lifestyle coaching programs. I think we can hop to the next slide.
Yep, and so this is, you can see what Rob just shared. It's very similar to the summary for both carriers. We actually listed both Kaiser and Moda, understanding their own unique model, but it's under the umbrella of general lifestyle coaching. A lot of either NA or not, kind of low information here. So Eligible numbers are pretty big because it's really just open to anyone 18 and older. The total enrolled numbers generally is around less than 1% to 2%. Not able to provide a lot of benchmark information here. And again, you can see this is a trend generally with the carrier managed programs, right? Like Kalia talked through the Kaiser weight management program. We saw limited data there. For the average number of coaching sessions per participant at 6 months, the benchmark is 1. And again, I think even though that's benchmark, sort of a question of like, is 1 really what we should be shooting for within 6 months? But you can see that there's actually some good data here for some of the years around, particularly MODA's program of having a higher number of coaching sessions, particularly for low and medium acuity members. If we go to the next slide, we have a little bit more around member experience and health equity. So member experience, they were able to provide, both Kaiser and MODA, their satisfaction. Kaiser's average satisfaction rating for health coaches is actually, out of 5, about 4.77, and 4.82 for being treated in a caring manner. So overall positive there. And in a similar way, MODA said that 100% of members rated 4 or 5 out of 5 on all of the member satisfaction survey questions. From a health equity lens, for Kaiser, the majority of those engaging and MODA are both those who identify as female. Kaiser, it's a little bit of a younger group, on average 19 to 44, followed by 45 to 64 plus who are living in urban areas. Whereas in MODA, it tends to skew a little older, anywhere between 40 and 59 on average are those who are most participating. There are some filters members can search for providers, gender, languages spoken, and specialty, but otherwise, things like race and ethnicity, or other maybe like LGBTQ plus status, that would be internal and optional for a member looking for a provider of choice in certain areas. And then they both provided information around how they kind of embed diversity and inclusion as a core value and utilizing member claims and social determinants as possible with some of their, kind of member identification. Okay, next slide, please. This shows the clinical operational outcomes we looked at for general lifestyle coaching. Again, looking at number of risks relative to number of coaching sessions, participants that achieved the program's goal, self-reported perception of health and well-being. It's a little bit different metrics from some of the other categories, but a lot of this was either not provided or not tracked at this time, where MODA did have some information around the percent of participants that achieved the program's target goal, which, is we put as a yellow. We'd like to see those numbers higher, but the overall theme here is just unfortunately not a lot of information being able to be shared on outcomes. Okay, next slide, please. And a similar note here, not a lot of information here. There is some kind of work to be able to provide some of these data points by MODA in the future. Next slide, please. Okay, you all have hung with us this long. I'm going to hand it back to Rob for these last few sort of summary and insights, next step slides.
All right. We made it to the sort of summary slide of all of this data that you've just observed and allowed us to share with you. So We'll do our best to summarize on these next couple of slides. We also have some recommendations to make based on where we move forward from here. Certainly welcome any questions or discussion as well. I think fairly consistent themes in a lot that the engagement among all vendors isn't where we would want it to be. Certainly would prefer members to be engaging more. In comparing the vendors themselves, the engagement, again, in Omada, Preedy, and Verta specifically, their engagement, again, consistently is lower than we would want. However, their outcomes are better in general than some of the other programs that we evaluated. However, there are still some gaps. Engagement in Weight Watchers is good, the best of what we looked at, but there are some gaps in outcomes for the Weight Watchers program. However, just acknowledging the fact that program is very, very well received across all the populations that it's offered to. Teladoc specifically, consistent with the other vendors, their engagement is low and there are significant performance gaps. We saw both in the pre-diabetes program that members are actually increasing BMI, and there wasn't a significant reduction in A1C for those living with diabetes. Also, we really were unable to assess the overall outcomes and performance of the lifestyle management programs with their with the lack of outcomes data. So there's opportunity here. So really, and as I answered earlier to one of the questions, is as part of the renewal process to really select appropriate and feasible outcomes to include in the contract to require the vendors to report on an agreed upon cadence. It is, I will acknowledge, and we saw some areas throughout that it is often challenging to provide the exact same clinical metrics for each program because they're designed a little differently. And that's fair. The goal really will be to ask the vendors to provide what's meaningful to that specific program, and then we can work from there. To the degree they can be consistent, we would like that to be able to compare the programs across the carriers. There are some differences in terms of model and how they're delivered. Also, this group and the health equity work group can work with vendors on additional initiatives to advance health equity beyond just supporting Spanish-speaking members, such as things like required cultural competency trainings of their member-facing staff. So quite a few opportunities for both groups to take on there. And then engagement strategies. Think about ways among the different carriers to maximize that engagement. There were, for an example here, there were differences in satisfaction and outcomes from Omada's diabetes prevention program between that of the same program offered for Providence and Kaiser. So, sort of digging into that and why engagement is different from one carrier to another in the same program and how to maximize that. All right, the next couple slides cover the vendors in specific in a really rolled up fashion, along with our recommended actions. And what you'll see here, the insights column in the middle is really just a really high level summary of what we saw per vendor that we just covered over the last hour and a half or so. And then the right-hand side is a potential recommended action for us to move forward with. So this is really the recommendation piece of the data you just saw. So for the diabetes prevention vendors, again, I won't repeat everything here, but the two vendors that are performing the best are Omada and Preedy for the PEB and OEB populations and the populations that they serve. So for both of those, we would recommend, of course, keeping the programs and then working, as we mentioned on the prior slide, to develop the most appropriate metrics for them to report on, watch it closely, think about all those opportunities that we have in place to be able to maximize the engagement and improve the outcomes. Teladoc, though, for this population was challenging in terms of increases in BMI for those with fewer coaching sessions, for example. So we would recommend considering replacing or consolidating the Teladoc program for the PEB members for diabetes prevention. For weight management. So Weight Watchers, this is, again, it's a very, I've said a few times, a very well-received program in the population. However, while a lot of members were enrolled, the outcomes weren't as we would necessarily hope for them to be. So this could be a potential option to look at replacement or consolidation. However, it is, a program where we'll need to weigh, I know that the cost benefit piece. I know that I think it's a not to exceed cost, so we'll want to look closely at how that is structured when moving forward with the recommendation. But bottom line in terms of the overall performance, so there's room for improvement. The OMADA program for PEB and OEB members for weight management, newer program, but however, the results were better overall than those that were in corresponding programs. So this one is a keep and watch candidate, potential candidate for expansion if you decide to move from one to another. And then the Kaiser program, that there's enrollment about 5%. Was difficult to assess the impact. If there's no added cost for this program, it's a keep and watch because members are able to participate in it and they're able to be part of the program that they so choose. But we do want to push to try to get as many data as possible. All right, next slide. For the diabetes management vendors, the vendor that's performing the best in terms of overall outcomes is Virta. And again, we noted here that they may be that they could be a keep and watch and to evaluate the outcomes, and that they may be a candidate for potential expansion because similar to the pre-diabetes program, Teladoc is not performing well with the lackluster reduction in A1C for members at higher clinical levels. So it could be an opportunity for replacement or consolidation of that program as well. You'll see in the last 3 programs that it was really difficult to assess the impact. Very meaningful enrollment for the Kaiser Diabetes Management Program. And then the lifestyle management coaching programs in general, very difficult to assess. And so these, as long as there's no cost associated, we have them in the keep and watch category. However, if it is something that is being paid for, we suggest consolidating with others that just due to the value and the inability to report. Right, Robert, question. It is actually time for questions. This is perfect.
Well, I timed that well then. When you say added cost, is it added cost to OEB or is it added cost to individual members?
To PEB and OEB.
PEB and OEB. So, okay, got it. So would we know whether or not it's an added cost at this point? If it's PEB and OEB?
Review. We need to review the specific contracts to determine how those costs are actually structured, and that's part of the renewal process.
Okay, thanks.
Do we have other questions? Andy, or no, sorry, Dr. Lara.
You can call me Andy too.
Thank you.
I just have a follow-up comment. So thank you for this report. It's really important, but I see like a strong data limitation, and you mentioned, Rob, this too. So I see the engagement low, and then the survey number is really small too, the collecting data. And here we're analyzing 3 years, right? So 2023 to 2025. So from a biostatistics point of view, when the sample is too small, the data is not representative of the study. So in this session will be of the population that we are studying. So moving forward, I think it's key that we open this to when we redo the contract and kind of amplify that specific collecting data, because as Kimberly mentioned, it's just like we can actually demographic data, that's basic. So and just to have like because we're assessing, and then we now we don't have that data, so we are going to keep 1 to 3 years more doing this. So I just want to be like a little more proactive when we connect with our vendors and try to figure out like, okay, the population we're serving here is this, and we need to kind of address this. And it's not only it's going to be specific for race or ethnicity, right? It's going to be like a more broader picture. So I just want to add that comment. Thank you.
You're absolutely right, Dr. Lara. We agree. And that so two things on that that I would just add on to, or that this is why we want increased engagement, because the more engagement we have, the more we can note the outcomes, and the better sample size, the better data we have. The other piece that we're adding and requesting of the carriers are, how can we ensure members are completing satisfaction surveys? So we don't have not enough people completed satisfaction surveys, so we don't know how the program is performing. So we also want to make sure we're collecting the data up front to make sure that we're able to track those outcomes. So we completely agree. Any other questions? There's a lot of information to get through, so we appreciate your attention.
And we do have kind of some action that we've been asked for, unless there were too many questions. We were trying to figure that out, right? So if we had too many outlying questions, and as SEOW, we just felt like we didn't have a good grasp on it, then we weren't going to ask for action. But it does look like, we're asking for some action on what we want to do as far as going back to our boards, PEB and OEB. And so if maybe you could form what is it that you exactly need from the SEOW, that would be helpful.
So I think the biggest consideration is really on the two programs that are offered by Teladoc. And so the question there would be then if we want those to be replaced by then any other program. And then the question becomes, if yes, what? We've also proposed in the renewal letters the question about if any of these programs can be expanded. So for example, can OMADA or VERTA be expanded to include that Teladoc population if the board's so decided to replace that? So we do have to do some work in the specific renewal to think about, if we do this, then what? And so I think that's ultimately what we would need, or the recommendation is to explore that further. And I welcome any other Mercer team members to answer that better, but who are more closer to the renewal process. Andrew.
Yeah. Hey, yeah, I agree with everything, Robin. Yeah, it's a good question, Kimberly. As you know, this is one of the years where recommendations are likely going to be a little bit different for PEB and OEB, largely due to that RFP that's ongoing. And so, without going into a ton of detail, this is an area where we posed questions to the bidders of the RFP around point solutions and integrating with third parties and that sort of thing. And as you know, we're not doing renewal letters for the medical carriers this year because of the RFP. So for many of the existing solutions that are either subcontracted through the medical carriers or homegrown programs through the medical carriers, I think we're on a little bit of a pause for PEB until we've worked through the RFP process. However, there are other vendors that we've talked about here, like Weight Watchers, that are on a direct contract basis with the state. And so that is one that we'll be talking about here in a couple of weeks when we get through the round one renewals. And so just wanted to provide a little bit of context in terms, especially for the PEB board members, as you're thinking through these results and recommendations, just wanted to provide that so you have a sense for where the focus area will be in a couple of weeks, and then as we work through the renewals over the next couple months.
Thank you, Andrew. And I did want to make a note that Greg Clauser and Andy Foltz did join us way back in the beginning of this meeting. So, so for the minutes, I do want them to get credit for being here to see the presentation. So Bill or Robert, do you have any feedback on what you would like? Because OEB, of course, you're more impacted, where PEB, we have to take a wait and see approach. You know, Weight Watchers is very well known, and that's probably why its numbers are the way they are. It's disappointing that it doesn't have a better return for it, because there is a cost to Weight Watchers, and we've talked about it in past meetings during renewal on what Weight Watchers costs our boards. So I don't know if you guys have anything you want to add.
So, Bill, how many years has Weight Watchers been on the alert list for SEOW? It seems like to me it's been every year since I've been on SEOW.
Yeah, I'd say 7.
Yeah.
You know, they keep remolding themselves, and they have just currently remolded themselves yet again. You know, with a big advertising marketing campaign on national TV. It's kind of a program that requires, in my opinion, a champion in each building or small district. Like someone who steps up and says, "Hey, I'm the leader of the group. We're going to meet every Wednesday," you know, and kind of that's how that program rolls. And it was good for a while, but it kind of fell off, especially around COVID. It died. Changing the subject for me, the only reason I'm hesitating on saying let's do some action is, to be honest with you, in this particular presentation, I was speed filtering data based on what I had read over the weekend, and then hearing the presentation, seeing some pitfalls or some errors in my understanding over the weekend, and then I'm speed filtering again during the last 2 hours, and I'm not totally comfortable that my speed filtering is 100% correct. In understanding, I do get to the recommended actions. I see some things that are not in your recommendations that I kind of picked out through this amount of data coming at me that are not here. So I'm wondering, is it my misunderstanding, or did I miss something, or did I pick up something that was not true? So I'm a little bit questioning myself now and thinking about, should I just roll through this whole presentation slowly tonight and tomorrow and revisit it based on some of the misconceptions that I now realize in your presentation that I did over the weekend? So I'm kind of stuck right at the moment. So thinking about it right now.
Okay, thank you, Bill. Glenn?
Well, based on what Bill said, I'm wondering for a timing issue, since I would assume, Rob, what you need action on are the ones where you're saying consider replacement or consolidation. And well, I guess everyone, but you know, especially for the consider replacement and consolidation. But from what Bill said, there's a lot of data here. So I'm wondering, and this is kind of a question to Mercer, is would it be okay if see how, you know, stepped back, had a month to kind of review, and then in March made its recommendations, especially on those where you're asking for a specific action on the either the replacement or consolidation?
Hi, Glenn. This is Kirsten. Yeah, for sure we have time to do that. And Andrew mentioned it works for the PEP team also. Bill, we really appreciate the time you've taken to look at the data and the presentation and really think about these topics. And we would really welcome, and this goes for the whole SEOW committee as well, if you did come away from the presentation today or the advanced reading with additional questions, it would really help the Mercer team focus additional work in helping to answer your questions if you'd share those with us. So you're welcome to email Glenn, and he could pass those questions along, or you could email Mercer directly as well. And we can come back in another month and have a follow-up conversation. Thanks, everybody.
Thank you so much.
Couple of things on this. So, yeah, I think waiting a month is good. What I'd like to see for me to make a more informed decision is the replacement piece. There's no way I can consider what a replacement would look like in, my stupid world that I have. So when I'm looking at that, I'm thinking consolidation unless, somebody comes up with, here's a possible replacement. So, and maybe that's what we're intending there, but I'm not positive. And then the other piece that I'd like to have more information on is the added cost piece, because it would be good to know what is the added cost. And I know we've done that with Weight Watchers, for example, over the years, and the cost has been, fairly minimal. We've been able to train them a little bit. So to do a cost benefit analysis, I think we actually need to know the cost a little bit.
Thank you. That's good, Robert. I think that, and I think that this is sound, right? This is, we have time to absorb because, I mean, all of us are looking at these screens and yes, we did have the deck ahead of this meeting so we could look at it. But until somebody speaks to you directly, sometimes the data, you're just trying to figure out what it means to you. So I think that we can, if Bill has any extra questions, get those to Mercer. We can definitely, our March meeting, we should have a better handle on what we've absorbed. And then maybe some of the things that Robert brought up about the added cost and what that would look like. That would be good if we could get something. So, but Rob, Katie, and Kalia, thank you so much for this presentation. And all the team, thank you for the good questions. And unless somebody has another question, so we're going to table and revisit in March our answers to what the recommended action. We have a break scheduled. Does anybody have any questions, or are we ready to go to break?
Break.
Okay. It says 5 minutes. So that's a very quick break. I'll put it in the chat. But if it's more like 7 minutes, I'm not going to hold any of you to the fire. So we will see you back after the break. Thank you.
Oh.
No, you're fine. What do you got?
I have a meeting in Albany, so about 12 or 11:45 or so, I'm going to transition to my phone. Just want to let you know that. Okay.
Okay, perfect. Thank you so much, Robert.
Thanks.
Hi, Kimberly. Can you hear me okay?
I can. Absolutely.
Good.
Thank you so much, Ian. That is such a fast break. I am sorry. I didn't even try to go to the restroom. You guys, it's prison. I can't get down the hallway through 3 doors in 5 minutes. So it is what it is. Let's see if my other board members have their. Yes, Greg.
I just wanted to say sorry, I was a little late.
I can barely hear you.
Oh, can you hear me a little better?
Yes, yes.
Sorry, I was a little late in getting home. There was a break-in next door, and they were apprehending the individual in the front yard.
Oh, kind of exciting, I guess.
Yeah, just right across the street. So
yeah, great. Well, we're glad you're here. And I did see, I was watching and I saw when you got here. So I was trying to make sure because I didn't want to ignore anybody. And Andy had some technical difficulties. So she was here, but unable to tell us she was here. So anyway, so it looks like we are ready to get started. And so next up is clinical renewal priorities, and cardiovascular health is what we're going to be talking about. So good morning, or yes, we're still morning. So good morning, Dr. Chang. Thank you.
Thank you. And thank you, everybody, for the privilege of your time today. I will lead this discussion on what we're calling cardiovascular health. So these are the sort of the heart and circulatory related conditions that are so relevant and prevalent to many of our educators and associates. So Maya, next slide, please. So the goal for today in this section is to review the optimal treatments for cardiovascular care. And really, when we're talking about optimal, we're starting to think innovative, right? Innovation beyond the traditional doctor office appointment care, which we'll show is so critical to helping our educators and associates achieve their best clinical care and outcomes possible. And then tied to that, we'll be kicking off the gap analysis and rolling that into the 2026-2027 renewals. So with that, let's go to the next slide. So this is the agenda for today. We'll go through some of the background, the context for why we are now continuing this conversation and exploration around cardiovascular care, and specifically optimization of that care. And look into some discussion around looking towards our carrier partners and aligning and supporting the things that we'll be discussing today. And then we'll get to next step in terms of planning for the next SEOW meeting and potentially the request, suggestion, recommendation to the OEB and PED boards, respectively. Okay, next slide. And the next one. So quickly, again, we've had a few SEOW meetings on this topic. So to remind everybody, the cardiovascular health is so critical and important to our educators and associates for two key reasons. One, we were seeing a high prevalence of these conditions related to the members, the educators and associates. So they matter to a large proportion of the population. Simultaneously, we were seeing high costs of care related to some of the more serious diseases and conditions that result in cardiovascular health. And to support cardiovascular health innovations, some of the things that we've added to our renewal letters and our questions to the carrier partners included the following: kind of what adherence programs, so ways to improve the members' access and compliance with medications that we know can be so effective. Our programs available to help with the monitoring of outcomes, for example, around high cholesterol and high blood pressure. These two are things that conditions that are very prevalent, and where they're controlled, they lead to lower risk and lower progression to the cardiovascular severe diseases that we're trying to avoid. Our tailored prevention and screening strategies available to population, specifically with around disparities. We know the condition prevalence is not uniform across all race and ethnicity. Similarly, we know that treatments don't always are not always even or equitable across those races and ethnicities. So what can we see and what can we learn? What opportunities exist to collaborate with clinics, providers serving the high prevalence population or high risk population to improve their treatment and outcomes? What early detection options are in place around cardiovascular conditions? And then what integration efforts are underway between medical and dental to address and provide a holistic approach, a member-centric approach to cardiovascular health. So these are some of the things that we've posed to our carrier partners as part of the renewal process. Next slide. Okay, and the next one. So what does success look like if we can optimize cardiovascular care beyond the traditional, provider, patient office visit care? The hope is that we start to become more holistic in our approach, and we start trying to drive towards outcomes and really closing the gaps where we know what is standard of care based on evidence-based guidelines and practice recommendations versus what is currently taking place. And some of the things that can result from this innovation and optimization could be earlier treatment initiation, right? Knowing members who can benefit from some of these preventative treatments and getting those initiated earlier, sooner. Improving medication adherence, specifically around statins, which are used for high cholesterol, as well as high blood pressure medication. When we see emergency room visits, which is obviously very costly and not always the most efficient and best place to care for individuals with high blood pressure, having those events be something that could be leveraged to help with patient education and care subsequently. We want to lower long-term cardiovascular event rates. Ultimately, that's the benefit to the members, is reducing those severe cardiovascular illnesses and events. And it also benefits the plan because those are the most costly contexts of care. And ultimately, by improving and addressing some of the underlying risk factors, we are going to improve employee productivity and satisfaction over periods of time. So that is the goal if we can review some of these opportunities for optimization. Next slide. So if we step back and making sure we're aligned across OHA, OEB, and PEB, we can see that we are, right? This innovation aligns across all three stakeholders in the sense that ultimately we're about trying to improve quality, access, and reliability of care for all of Oregonians, but specifically, obviously, our educators and associates within the context of OEB and PEB. By doing so, we not only improve their health and lifelong health, but we get to contain and help to improve the cost of care, which is so critical for various reasons as we're trying to struggle with next year's plan design. And the alignment with OEB and PEB is really this uniform in the sense of providing affordable benefit and services, being flexible, and accounting for the unique needs of the population within each group. Next slide, please. And in our efforts for doing this, again, just making sure we're aligned, we want to serve and make sure that we're cognizant of OEB goals and PEB goals and core values and the framework that's been outlined for us in our efforts, right? Which is always around equitable access to deliver quality care, mindful of cost and the impact of affordability. And ultimately, it's the member journey, which is inclusive of member education and member experience. So with that backdrop, let's kind of start jumping into some of the specifics around what are we talking about when we say cardiovascular optimization and innovation. Next slide, please. And before I start this is purely my slide to just ensure that we have some reasonableness in terms of expectation. So the caveat that I want to outline here is, one, What we see through analysis and plan experience is that the current approach for cardiovascular care is not ideal. It is a very reactive care model predominantly, meaning we wait for associates and educators to say that they don't feel well or they seek care. And then the medical system, the providers intervene and try to provide guidance, prescribe medication, etc. Right. So what we know is without adjusting this current approach, some of the data that we presented previously, the similar results will just perpetuate. Right. So not to quote this overquoted, but insanity is wanting a different outcomes, but we're not changing anything. So that's the risk and that's our reality. But that being said, what we're also talking about is optimizing processes, but we still have educators and associates having to take action, make better choices, and follow through on some of the recommendations and processes that we're going to put in front of them. So we know change is hard and behavioral modification takes time. Culture and peer-to-peer influences also matter. So all these dynamics are at play. So the point is, what we're focusing on here is trying to put in processes and programs that can meet the need of our broad population, but we're also realistic that we want to see how well these programs are working. And just like in the previous presentation, we want to analyze and look at engagement through process to activity to outcome, and then figure out what's working and what's not, and continuously improving and optimizing our approach to deliver the best results to our diverse population that we serve. So that caveat is very important because right now we're talking about process and programs that I think are critical ingredients, recognizing that at the end of the day, once we put these in, we have to just see how well the members gravitate to these programs and how well they get adopted and the outcomes that we are achieving. Next slide, Maya. Okay, so the next sections that we'll go through, Mercer kind of pulled from our experiences with other client employer groups, as well as our knowledge of what takes place broadly in the healthcare ecosystem to go through some of the opportunities and examples of how we can optimize cardiovascular care. We kind of broadly group them into these three pillars to provide some context and alignment. The first pillar is really about being proactive. Again, it's moving away from this reactive medical care model where a patient has to call in and make a request for medical service and care. There's an opportunity to build proactive interventions, helping get ahead of the needs of the individuals and engaging them at a more optimal time. So that's the pillar one sort of interventions that we'll kind of walk through. The second pillar is around removing barriers that make it hard for both members and providers to achieve this optimal care. The last pillar is all about the care experience, understanding our population, some of their challenges, some of their intrinsic biases, preferences, cultural norms, and things like that. How can we make it easier and improve the experience of each associate and educator so that they can feel like they want to engage and they can achieve the benefit that we hope to expect for them. So we'll kind of walk through these three pillars in terms of some of the optimization opportunities. Next slide. Okay. So feel free to ask questions as we go through these exemplars. The goal here is to help the you all folks here to see what's the world of possibilities and see what may be of priority or of specific interest and opportunity for the populations that you know so well. So around pillar one, it is the proactive interventions. So broadly, there's these three opportunities. One is just to be targeting asymptomatic risk earlier. As we're talking about cardiovascular diseases, the ones that we want to avoid are the heart attacks, the strokes, the renal failures, etc. But early on, some of the conditions, many of us don't feel ill, or we don't think we're um, suffering from the consequences of these conditions. Two examples: high blood pressure, high cholesterol. Many folks who have those conditions feel like, I don't feel sick, I must be okay. We know that's not true, because these kind of physiological processes are always working in the background, and they do lead to cardiovascular disease. So how can we inform members in advance, outreach to them in a way that gets them mindful of the risk factors, and in a way helps them to be more proactive and collaborating with their providers, clinicians, to understand the risk and to come up with a care plan to address these risks through preventions and early medication treatment specifically. The second approach is kind of focusing on high impact moments. Sometimes patients don't realize they have these underlying conditions until something happens and they end up in the emergency room. They're well taken care of for that acute situation. They're stabilized, but then we send them home. But we miss an opportunity to say, okay, this happened because of XYZ. And let's work on assessing that and coming up with a treatment plan. So we avoid that situation again. But more importantly, address the underlying condition or risk factor that led to that. So again, in the reactive model of care, the onus is on that individual to say, wow, I went to the emergency room for this. I don't like that. I don't want that again. Let me call my physician, figure out what's going on, and can I get ahead of it? The opportunity is to turn that around and say, okay, carrier A, I can see the claims for this. Obviously, this is a new condition for this individual. Let's engage that individual so we can get ahead of it before they ask, before they think they need to have a care plan. So that's what we mean by sort of high impact moments. That can be the initiation of care engagement. The third one is measures that matter. You know, part of our quality metrics center around the HEDIS measures that we've been tracking across PEB and OET for year over year. And they are important because they allow us to sort of have a high level sense of how well we're doing on some of these traditional clinical quality measures. What they don't inform us is, how do we improve on them, right? So kind of like what we're doing with type 2 diabetes is getting to that next level of analytics. There's the opportunity for us to collaborate, for the carriers to dive deeper into each of those HEDIS measures to say, we're doing okay. We're maybe the top 75 percentile. However, if we want to get to that next level, it is going to be understanding what's missing from those additional quartile. Who are we not engaging with? Who's missing, falling off the mark in terms of each of those measures? So again, it's just a more clinically based, data-driven approach to quality improvement. And that's an opportunity that we have. So those are the pillar ones. It's just being proactive. There's things that are being done currently, but we may not be fully visible or transparent about what's going on or how well they're working. Okay, next slide, pillar 2. So this is all about removing any points of friction. If we feel these are the right things to do, then making it easy for both our providers, caregivers, as well as members is going to be important. The first one is around high value, low total cost of intervention services. I know that we have high value, low cost formularies in place, but in some scenarios we have in place a zero copay for anything that's guideline recommended related to cardiovascular care. $0 is just the ultimate, zero friction, right? It's removing any financial barriers or hiccups to potentially taking these preventative medications that can avoid the more severe cardiovascular conditions. So again, it's just pushing that high value formulary a little further and reducing that as a potential barrier. But if we do that, it is about also educating our members and getting them knowledgeable so that they don't have in their mind that, hey, this is not something that's going to be a financial burden for me, even if it's a low copay. We have we have a fantastic clinical partner in terms of pharmacists. So the next intervention is about leveraging their relationship and where they interact with our associates and educators in a way that helps that individual basically become better informed of the importance of the medication, helping them with their refills, staying current on the medication, staying adherent to the prescription that was provided in a very efficient and low friction way. The last opportunity is around easing provider burden. Again, there's within healthcare delivery systems, especially when in the context of electronic prescribing and electronic health record, there's ways to improve and streamline what a clinician needs to do to prescribe, place orders, and to make it easy to have a turnkey process from when they feel they are making treatment recommendation in the form of prescription or orders to the processing of that order to the individual either receiving the medication or following through with tests and other things that are best practices. So again, it's where are there friction now in terms of how processes are defined and where it doesn't make sense or it's not adding value, like certain prior authorizations perhaps, let's remove them as a barrier. Okay, the last pillar, pillar 3. This is about improving the care experience, and we kind of have 4 exemplars of where other organizations have tried to sort of focus on this. First one is just to simplify the care journey. On the website, we've got educators and associates who, in the context of school operation, is challenging. Similarly, we have that on the PEB side based on their role within certain organizations or institutions that we can say, these are the things that you need to do to improve your health and to reduce the risk of cardiovascular illness down the road. But the process may just be not aligned to the realities of their lifestyle. So how do we optimize that? What's in place right now? We have virtual care. In the past, we've kind of taken a look at the utilization of virtual care, and they are not as high as we would like. And that's a concern given the value of connecting with those individuals so that we can keep them connected to their providers and provide sort of checks and balance in terms of how well they're progressing and improving. So there's opportunities for leveraging that. Digital engagement is still a potential opportunity that we maybe have not maximized. We acknowledge that digital literacy is not uniform across all our population and associates, but to the extent that it is available or it can be leveraged, how well are we taking advantage of that and making it easy to both communicate but also collect data specifically around cardiovascular risk factors. Employer partnership strategies. We have some programs in place. They can work. They work better when engagement is high and when members and associates follow through and stay engaged from participation through to outcomes, right? So in the last session, we talked about some of the constraints when engagements are low. All bets are off because the cohort size is too small, both in terms of the number of members that get benefit from it, but also the benefit to the plan in terms of improved health and lower costs for downstream care. So how do we optimize and really improve the partnerships and optimize the point solutions and programs that we choose to align with? And the last one is personalization. And personalization has many dimensions. One is obviously one size does not fit all, right? So just like we're seeing, for whatever reason, the same program can work better within one organization than another. So we have to understand what's the connection point. Is it culture? Is it peer-to-peer? Or is there some internal champion that is helping that process, that engagement and awareness that leads to the improvement in participation, engagement, and ultimately the outcome? And obviously, we have a diverse population, so we have to be sensitive and aware of the diverse needs and ways to better support those individuals across social demographics, race, ethnicity, and meet them where they are at. So all that is under personalization, and are we doing the best we can to meet our members where they're at? So those are sort of a broad industry perspective of things that can be done to support individuals and groups through cardiovascular care optimization, leading to reduced disease burden, illness progression, and ultimately improving sort of the health and well-being of these individuals with these risk factors. So let me pause there. Next slide, I think, is yeah. So before I go into the next section, let me pause there because I kind of described top down what are possibilities, and open to any questions about some of these ideas and approaches. Yes, Bill.
So I was thinking while you're going through that, and all good, right? Don't get me wrong. I was just wondering, as you were talking about with technology adherence and abilities, is it the same from 20 years ago to 10 years ago to today? If we looked at a focus group of a diverse group of 10 individuals who showed up at the ER with a 98% artery clot, because they fell over at Costco. Why did it take you so long to realize the symptoms? What with today's technology and what and what you see, what is still the current causes of why it took you to pass out at Costco and get ambulatory services to get here? Right. Just wondering what's changed, or if anything's changed. Maybe it's still like it was 30 years ago. Who knows? I'm just wondering.
I think the range of underlying scenarios or conditions are still there. I think the ratio and distribution has evolved over time. So we still have those that feel they're, the invincible. It's not me. I'm fine, and they get caught off guard, and they do have the chest pain at an unexpected time. However, our population understanding has evolved and changed. Our level of proactive. So statins have been hugely impactful, right? From the first time Lipitor came out till now, the utilization rate has gone up. That being said, we also know that the denominator has also gone up in the US, right? Because of underlying risk factors like the prevalence of obesity and type 2 diabetes and the increased use of consumption of ultra processed food, high fructose beverages. So those things have evolved as well. So both curves are changing. And the question is, are we getting ahead of it enough? So the causes are still there. The distribution has shifted. And the outcomes has also shifted, right? We have individuals now familiar with the automatic electronic defibrillator, and they're more accessible. So we are now able to intervene earlier. So the rate that we are able to save individuals has improved. But the cause of why somebody has those acute events, they're still there.
And we also haven't moved detection earlier with newer technologies. Right. Well, we don't even have newer technologies. Maybe we need to invent a newer technology, but we need to get something that says, hey, you're heading for a collapse at Costco, not you just collapsed at Costco. Right.
Yeah, and I think one good example, and I think Apple did publish some early data, right? They can detect atrial fibrillation through their Apple Watch. So that's huge because atrial fibrillation, suddenly your heart pumps ineffectively. But now that watch can warn you of that. That's the first. And we'll see how much more we can do with it. But so far, that's the first example of continuous monitoring capability.
So get everybody cardio mobile, right? That's right.
I travel with it, so it's been helpful for me. I've only used it once as a, uh, one of those, is there a physician in the room kind of situation. But I can get a 6-lead EKG right away. So yes, very helpful.
Okay, and just thinking out loud. That's all. Sorry, just
No,
kind of chatting, right?
and the challenge is how do we systematize that across any group, right? So
Yeah.
everything you've asked has been sort of bottoms up. It's just slow evolution through social dynamics and healthcare and medical knowledge disseminating into the public. But within the OWEB and PEB, are there ways and opportunities to push something further? There are challenges and constraints because with any digital enablement, there may be a financial price tag to it. And we're cognizant of that. So obviously, in going through this list, it's what are the possibilities? And as we go into the next section, we'll go into what are things that you may want to consider as the ask back to the carriers to consider, and or what would be recommendations you make to OEB and PEB board as part of the renewal for next year. Okay, next slide. 2 slides forward. So to catch everybody up to speed, we have the round 1 renewal letters. I kind of listed some of the questions we posed back to the carriers in that round 1. And this is very brief, just exemplars of some of the things we've been coming away from the round 1 responses. So some of those examples I just went through, our carrier partners are, in fact, they do have programs in place, and they describe what are available to our educators and associates. And I just used some examples here from each of our carrier partners. Kaiser has Health Connect. Moda has a platform that includes algorithms that help with early screening and initiation of treatment for cardiovascular condition. Providence similarly has a portal that prompts members to seek out the visit so that some of these health risk factors can be addressed with their clinician. So that's all good. So we have exemplars that are carrying forward into our carrier partners. The feedback and the requests for round 2 that we've started initiating really comes down to help us understand for those programs that are in place, kind of like what we went through with diabetes and weight management. Let's look under the hood to know, well, you've said these programs are in place. Are they working for our educators and associates? Are all the diverse needs of our associates and educators equally being met? Are we accounting for diversity, unique needs, non-English speaking members, for example? So it's really getting to that next level of evidence and outcomes. So that's some of the feedback we're going to provide to our carriers to get that level of insight. Because until then, I think all we can say is there's some things in place. We did get some high level stats and certain responses, but by and large, we just don't know enough about how well these are connecting to our members, how engaged our members are with these initiatives, and more importantly, the outcomes that we hope to see as a result of this, leading to reduced cardiovascular risk, and over time, reduce cardiovascular events, specifically the serious ones that we're trying to address. Next slide. So that leads to the next step, which we're proposing here is for the SEOW board to consider is, over the next several weeks, Mercer can work with OEB and BEP carriers as part of the renewal process to really do a little deeper dive, get some insights in terms of which one of those programs are aligned, and if it's been in place, if they can share some of the outcomes of these initiatives. And in the context of 26, 27 renewals, potentially new offerings or new strategies to make it more robust. Again, no one intervention or optimization is going to solve everything, nor is it going to be aligned or effective with everyone in the population, right? So it's really just having enough variable programs in place that collectively will serve our population well, that there's something for everybody in that offering in a way that meets somebody where they are at, that can lead to the benefit that we hope to achieve. And then in March, that at the SEOW meeting in March, we would have that kind of a overview feedback to review, and at which time we can decide what kind of recommendations to advance for OEB and PEB boards. So this is a proposal to table for this group here for consideration.
Well, we certainly appreciate the presentation, and it's always so hard because a lot of this goes back to folks being responsible for their care too, the personal responsibility, and knowing. I mean, I think there's fear for people don't want to know how bad maybe things are getting. They know they feel different. They're shortness of breath, all those different things that are happening that are some of the signs that we would be looking for. So I need a motion if somebody wants to make a motion to ask Mercer to continue this work and present findings to March's SEOW. I'd be open to that.
I'll make that motion. This bill.
Thank you, Bill.
I second that.
Thank you, Dr. Lara. Do we have any question? Are we all in favor? Aye. Greg.
Aye.
Thank you. I see the thumbs up, Robert. Well, Dr. Chang, it looks like you guys have some work to do. I think you've got some, the pillars are on the right track. I think that, I think I'm intrigued. I mean, I know that some stuff is already in place that you address, that you talked about. You're going to show that some of the carriers already do some of the things. But it'll be interesting to see what information we are able to gather.
Sounds good. Thank you.
Okay. Well, thank you. This has been a very, very informative SEOW. There's nothing about SEOW that we don't just cram in. Like, we are just so fact driven. And we have such a great collaboration with Mercer and our partners. And we're so appreciative to the provider network for giving us answers to our questions. And so I know we don't have Rose, but does somebody know if we had any public comment for our meeting?
There's no public comment.
Oh, thank you, Glenn, our fearless leader behind the scenes. Does anybody have anything for the good of the order? Anything that needs to be brought up? We saw in the chat, I think you guys, Mercer, you probably saw Dr. Lara, she makes some changes to the slide 16, I believe is the one that she mentioned, for inclusive language. And does anybody else have anything?
Kimberly, this is Ollie. I just wanted to give everyone a heads up. We'll have some legislative updates this afternoon for the OEB board and for PEB shortly as well.
Okay, good, good. Yeah, so we're giving you a little extra time because you have OEB. Does it start at 1:30?
1 o'clock, yeah.
1
Yeah.
o'clock straight up. So, okay, well, we're going to give you all a little time, and it's so good to see everybody. And we will see you in March. Thank you. Take care.
Thank you so much.
Bye.
Thanks.
Meeting adjourned.
Thank you.